how it is to be done. This procedure is being done on the Bohr's colposcope, and before doing the colposcopy, we should be ready with everything. What do I mean by everything is that our forms, equipment, instruments, and we should be aware of the history of the patient. That is, when was her last menstrual periods, what's her complaints, whether we are doing it for after screening or we are doing for the learning purpose, plus instrument trolley should be ready. Then labeling bottles, fluids. Fluid means acetic acid, freshly prepared. It has to be prepared that particular day only. And then Lugol's iodine, the quality of the Lugol's iodine, Tischler, Tischler for the taking the biopsy, and the labeling papers plus the marker pen. Everything should be ready. We have already discussed all this in the previous videos. Basically, this is for the showing the procedure. I will not go into the details of the findings, but in between I will tell you. So I'm starting the video. This has been done and it has been edited. That's what I wanted to tell you. After putting the patient in the lithotomy position, we have inserted the Cusco's speculum. So now you can see that the picture that there's some discharge. And then while doing the colposcopy, we should see everything through the colposcope, not through direct eyes. So we have cleaned the discharge. After that, you can see, I'll be stopping here to let you know that this is the columnar epithelium. It is pinkish, it is thrown into the folds, and it is a single layered. And here you can see the junction, that is between the columnar epithelium and the squamous epithelium. This is the junction, and it is this place where the maximum changes takes place. This is the new scamocolumnar junction, and we have to examine it very carefully. As I just now told, this is the metaplastic site. Here the metaplasia in the columnar epithelium will be starting because columnar epithelium is exposed to the acidic pH of the vagina. It is not the natural place. So this area is very important. Whole of this columnar epithelium is to be identified properly, whether the changes are simple metaplastic changes or some other changes in the terms of precancerous lesion is there, that needs to be seen. So after exposing the cervix, adequacy, satisfactory, whether the colposcopy is satisfactory or not, it is adequate or not, that is to be seen. After that, we will be cleaning with the normal saline. This is what we are doing, that we are cleaning with the normal saline. So it should be cleaned properly, not rubbed strenuously, so that it can start, otherwise it can start bleeding. You can see that we have cleaned it nicely, and you can see the external os, clear-cut pinkish squamous epithelium and the columnar epithelium. Now we have put the green filter. After the application of the normal saline, we need to remove the excess of the saline. That we do it. We have just done it. Now we have put the green filter so as to see the vessels. In the green filter, you can see there are markings. That is this is the neoscamocolumnar junction. This is the columnar epithelium. In routine, we should try that the speculums, it should not be visible during the colposcopy, and green, nowadays blue filter is also available, through which we can see the vessels very clearly. In this, I'm not going to show you the crypts right now. It is not visible here, but you can again make out that this is the neoscamocolumnar junction, and this is the columnar epithelium, and this is the pinkish squamous epithelium. So, and this is the glare of the speculum, which is coming on the ectocervix. Now we are applying the acetic acid. So as soon as we apply the acetic acid, you can see that we have to start the timer, because acetic acid is to be applied for at least 1 minute and then observed for 1 minute. We have already taught you the sweet score. So how quickly the area become aceto white, that is to be noted, and then how quickly it goes off, whether it retains for a longer time, it appears quickly, it goes off later. That is very significant. And nowadays, as per IARC, WHO, the findings of the acetic acid are more consistent and more valuable rather than Lugol's iodine. Of course, we are going to apply Lugol's iodine and see, but even if the findings of acetic acid, acetic acid has to be given more due importance, and multiple biopsy, which I have already told you. Even if you feel suspicious, that suspicious is the term, suppose you feel that the lesion is low grade, even then we need to take the biopsy. So we are applying the acetic acid. Here they will be keeping it for the 30 seconds. You can see the timer, and this is this is 6-time magnification. And now the timer is on. You can see that it is for there 14 seconds is elapsing. So on this basis, we can identify many lesions. So it is 25 seconds now. Soon it will be 30 seconds. So now you can see that the even columnar epithelium has turned up whitish, and this whole pinkish area also that has turned slightly whitish. You have to adjust the colposcope after application of the acetic acid so as to change the magnification. So tilting and all those we have to stabilize. We should try to maintain the stabilization of the colposcope. Now you can see that these areas, because we have increased the magnification, you can clearly see that this area, one is that the border becomes, neoscamocolumnar junction border becomes very clearly visible, and this is the area, whitish area, which has appeared, but it has appeared late. Here also you can see in the columnar epithelium, this is the area which has become more whitish, but not so white as which I can say that it is of much significance, but this is a metaplastic changes. Here you can see some of the tiles like appearances, and again while rotating you can see the neoscamocolumnar junction. This again area which has taken in the acetic in the columnar epithelium, it is appearing more whiter. So observe it, we need to. Now this is now becoming pinkish, red pinkish, the type of the columnar epithelium very quickly. And if we see here, it is still becoming white. You can see here lesion within the lesion, because this is less white, this is more whiter area. And so we need to corroborate with the Lugol's iodine. So just see that we have put the Lugol's iodine, and this area which has become quite white, I won't say that it is a very dense white, but it was dyed moderate white. So it hasn't taken the Lugol's iodine. It is not a mahogany brown. This is a mahogany brown iodine area. This is Lugol's iodine negative area. And see the type of the color which is shown by the columnar epithelium. So now we need to take the biopsies to uh, see what will be the results in these areas. Again, see the line. This squamocolumnar junction becomes much more easier to identify once we applied the acetic acid and after applying the Lugol's iodine. So the Lugol's iodine taken by the squamous epithelium is different. It has to be mahogany brown, and then the way it is taken by the columnar epithelium is different. It is a less because columnar epithelium doesn't take so much of the Lugol's iodine, so it appears a yellowish. And typical canary yellow is different. We will be showing in other films also in later, whichever the videos we are doing. But here, because this area, this particular area, here some area, because I showed you in the columnar epithelium and these areas, and we need to take the biopsy and see what are the results. So when you take the biopsy, you need to take it from the start from the lower cervix, upper cervix and lower cervix. One should not take it from the upper cervix immediately, because the bleeding will obscure the lesion on the lower cervix. Okay, so first take it from the lower cervix, and then other area. Suppose here we want to take, we need to take it from here. We'll take it from here and then from the upper cervix. So I'm showing you how the biopsy is taken. All this is should be done through the colposcope only, visualizing through the colposcope. So you can see here that this area is different from this area and it is still retained. Now, magnification we have done at 11. So whole cervix has to be visualized properly. And then this area also you can see a bit canary yellow. This is area is different. This is a bit canary yellow area. So now we are going to take the biopsies, which I am going to show you how you take the biopsy. Lower lip initially. When you start doing the colposcopies, because you have to adjust the colposcope, this shifting, and while putting the instrument, we are in habit of putting it after visualizing through the vagina. That is not to be done. That is why this occurs at the shifting of the colposcope because of the hand. So now we are taking the biopsy from the lower lip of the cervix around 5 to 6 o'clock position. So this is the Tischler, and see, they have taken the biopsy and we can, there's a bleeding. So this bleeding is, that is why from the lower lip it has to be taken, definitely from this area, which is not exactly the canary yellow, but it is seems to be abnormal. So after this we have taken the biopsy from this area. Now we'll be taking from the upper lip, that area which was showing aceto moderate aceto white area. So 3 biopsies we have taken. We are going to take from this cervix. So from the columnar epithelium, including the neo-squamocolumnar junction. See, this is what we have to need to learn, that we should not be, our colposcope should not be shifting from one place to other while taking the biopsy or while seeing it. So we have taken the biopsy and we'll control the bleeding now. If cautery is to be done, we'll do the cautery. Otherwise, simple application of the cotton ball for few seconds properly, because very tiny bits, hardly 0.5 millimeter, 0.5 centimeter, the bits will be. Hardly, it will be less than even, it will be hardly 2 or 3 bits only. So you can see that the whole procedure actually takes not more than 5 While taking the biopsy, we can reduce the magnification. So this is the procedure which we need to do in this way only. Thank you.